what percentage of care, let's focus on primary care for a second, can be delivered virtually? The answer is probably 80 to 90%, believe it or not. Like there's few instances where you need physical touch or diagnosis, right? Or treatment. And so I would say we're maybe one, if not two orders of magnitude removed from the potential to where we are today.
Today, we're speaking with Sean Mehra, the CEO and co-founder of HealthTap, who has a background in tech entrepreneurship and degrees in biomedical engineering from Yale and an MBA from Stanford. HealthTap is a virtual healthcare provider focused on primary care, connecting patients with US licensed, board-certified doctors that they choose and keep. In 2024, HealthTap began accepting nearly all insurances, including Medicare, and under Sean's leadership, it's enhancing healthcare accessibility through telemedicine across the United States. Sean, thanks so much for joining us.
I'm excited to be here. Thanks for having me.
Absolutely. You know, you've had a diverse career. You know, you started a couple companies, Payout Hub, GX Studios. Tell us a little bit about that, and then what got you into the healthcare space and prompted you to say, listen, I want to go and start HealthTap?
Yeah, it's interesting. I mean, I grew up a total computer geek. My dad bought me what was at the time an expensive computer, given our family income, that he said, play and break it and do whatever you want, which was honestly a privilege. So I learned how to program and code like very early on. But at the same time, I was coming from a family of doctors and I was a huge science geek. And just the respect that physicians have and how they use science to really fundamentally kind of help people, appealed to me. And so my default path was to go into medicine. So I go to college, I went to Yale, I was pre-med, I was biomedical engineering because it overlapped a lot with the pre-med requirements. But I found myself not spending any time on the pre-med stuff. I was kind of engrossed in this idea that, if I go into medicine, it was a relatively tried and true career path where every step of the way was carved out for the next 40 years. It really was. But with technology, you could literally have an idea, prototype it in a day and put it in the hands of real people and then scale it, in a week. And so the scale and speed of potential innovation was a order of the magnitude different, right? And that was more exciting to me. So lo and behold, I was, always at night kind of tinkering with startup ideas. And I was, the Mark Zuckerberg vintage. Like I was one of the first users on Facebook, just to date myself. Like that was the period of the internet that I grew up and went to college. Like Yale was the second school after Harvard that got Facebook when it was still Mark Zuckerberg's logo as the face. His face was the logo. Anyway, point is, I quickly found myself deviating from medicine. And my first startup was Student Planet. It was like an online campus, like flyer, event planning, groups sort of product. And I ended up serendipitously starting 2 online social gaming companies, literally having nothing to do with medicine or helping people, just because a buddy of mine had pitched this idea. Hey, you ever play the board game Risk? What if you could play with thousands of people on campus and leverage the fact that Yale has all these rivalries in the residential colleges? So we built this online social gaming company. It goes viral. We raise venture money. And now I'm running an online social gaming company with employees in college. And again, very far from medicine. But I think one thing that career path did for me was I learned very quickly how to build engaging technology, right? Because what is gaming at the end of the day? It's using a lot of psychology tactics to get people and motivate them to do certain actions in a digital medium. And after a couple of years of that and getting good at building these engaging games, the novelty died off. And I was missing that impact that I originally wanted in my career. So I said, you know what, I'm going to go to business school, take 2 years, figure things out. And I was on a global study trip. You get to pick a country you go to. So I went to India. That's where my family's from, but I never saw it from a business context. And while we were touring the country, we met with Dr. Devi Shetty. He's I think a very famous doctor that founded this hospital chain called the Narayana Hospital chain. And he was talking to us about how he used to be a practicing physician, but he started building these hospitals to totally rethink the design of a hospital. and how to deliver higher quality at higher scale at a lower cost, rethinking all design decisions from like how many nurses per floor, what are the walls made out of, do we need AC units in every window, like really just fundamentally thinking the operating model of a hospital. And he has built these huge centers of excellence that deliver really high quality care at a fraction of the cost anywhere in the country. And I think a light bulb just went off in my head. I said, here's a doctor who, instead of seeing one patient at a time for the next 40 years in this very like tried and true way, just rethought the whole paradigm and figured out a way to scale his impact, right? And so I just realized maybe there's an intersection between what I got good at doing, which is building these engaging software experiences, and why I wanted to originally be a doctor. And let's explore the overlap between those two worlds. And maybe I can go back to the roots of why I want to be a doctor, but applying technology. And it just happened to be around 2010 when I think this whole industry of, before it was called digital health, it was called mHealth or eHealth. It was a different name to it. It was very early on, even in the iPhone's life, right? It was just a slightly different time period. And I think it all became clear that that was going to be the wave in which doctors and patients interact going forward. And if I can establish myself as one of the early pioneers in this space and figure out where this is all going to gel out, I can be a pioneer and I can do what I want to do as a doctor, but at the scale I wanted to as a technologist. So
I love that. And I think, especially Greg, I'm sure you can resonate a lot to I think why he made the move out of clinical care as well. But, HealthTap is all about virtual primary care, right? And the stats that I was looking at, Productimity, is last year about 10 to 20% of all appointments were done virtually. What's the path to double this number, get us to 50% of all appointments being done virtually?
I think a lot of the stats look at what percentage of adults tried telemedicine last 12 months. What that doesn't do is really look at what percentage of care that can be delivered virtually is being delivered virtually. So while the stats might be like somewhere between 20 to 40% of adults have tried telemedicine, it doesn't speak to what type of telemedicine, how often they try it, how much is a regular part of the care they get. And so I think in reality, the percent adoption of telemedicine is a tiny fraction of that stat. However, if you speak to some tech-forward clinicians, what percentage of care, let's focus on primary care for a second, can be delivered virtually? The answer is probably 80 to 90%, believe it or not. Like there's few instances where you need physical touch or diagnosis, right? Or treatment. And so I would say we're maybe one, if not two orders of magnitude removed from the potential to where we are today. And so as much as the pandemic created this spike in demand and then it kind of regressed a little bit, it's kind of like it went from, 0 to 2% and fell back to 1% of its potential. So right now we're at a point where the pandemic's really kind of primed the market, as in physicians have gone from in 2010 being afraid of posting stuff on the internet out of like malpractice lawsuit fears to completely embracing that telemedicine needs to be a necessary part of the solution, to patients who said, you cannot replace physical care with anything by video, to video is way more convenient. Why don't we do this more often? And so we're at this point of crossing the chasm that we haven't quite fully done yet. The pandemic helped a lot, but it is now, I think, a function of a lot of companies like HealthTap to go from what we used to be doing, which is 15 years of education, right? Explaining to doctors and patients how it works, what's possible, to now just primarily driving adoption through marketing and engagement. It's a very different tactic because people want it. A lot of people don't know what exists and how to access it. A lot of people still think this is the after hours nurse hotline when I can't reach my doctor. But there's way more value to be had in virtual modality than just that use case.
Yeah. When you go from one-to-one, like you said before, from one-to-one to one-to-many, which that's kind of been almost like a coin phrase for me. It's like, man, I love making impact. I love the one-to-one interaction, but could I do one-to-many and make an even bigger impact?
Yeah.
Right. In society and medicine as a whole, which I think you resonated, what you said resonated very well with me. So I'm curious too, is obviously my specialty in being in more rehab medicine is very hands-on, right? And I know there's people out there that hear that 80 to 90% stat and think
it does not apply to PT. Almost by definition.
Yeah. Primarily, so it's 80, 90% primary care.
Yeah.
Okay.
Primary urgent care. Yeah.
I love it. I love it. So but I also really agree with you because I've done it. I've seen it done and I've done it, right? There's a huge barrier to care, especially from certain demographics of the population that can't access quality care from transportation or, their social situation or whatever it may be. They can't get to a primary care provider in an effective way, and you're solving that. So talk about that demographic that now currently or previously, didn't have access and now does, and what kind of impact does that have on medicine?
There's so many structural points of friction in accessing primary care. One is a physician shortage, right? There's just not enough doctors for the demand, such that, you end up seeing really long wait times. The average time to an appointment is 4 weeks, but the actual reality in some places is way beyond 4 weeks. 100%. It could be months.
Yes.
The second structural issue is the inefficient distribution of that supply, right? So there's large swaths of this country which are defined as medical deserts or primary care deserts, right? It could be a city. It's often a rural area, but they're just not physically proximate to a doctor to be seen in person. So how does technology maybe more efficiently distribute the limited supply we have? And then you have other kind of barriers. You have everything from affordability. I don't have insurance to the doctors around me don't accept my insurance. You'll see situations where in certain rural markets, there's only 1 or 2 doctors in town. And if they get into a tiff with the payer contracting folks and they drop out of network, there's no in-network option, right? So there's really situations where doctors can become unaffordably present in your area. Then you have transportation issues, you have tech literacy issues, all sorts of things that prevent people. Caregiver work shifts, I can't take time off of work, 9 to 5, Monday through Friday. I just can't. So all the clinics only operate during those hours. All of those things point back to a very basic solution that is tech, but low tech, right? Which is, let's take the limited physician supply we do have and distribute it more nationwide, more efficiently, more productively, so that we make the most of what we do have, right? And then enable access to them in as inclusive a way as possible. Make the app easy to use and make it really easy to pay for. Either because without insurance, it's pretty affordable, it's not that expensive. And with insurance, you don't have to pay any more than you would for a doctor that accepts insurance locally. Right? So it's that combination of things that needs to come together. And not once in that answer did I use the word AI.
That is the buzzword. What are some of the more unique marketing techniques or just ways for folks, especially in underserved markets, to get to know who you are that you've executed on that have worked well?
Yeah. A lot of digital health innovation, being that it was very venture capital backed, required hyper growth, right? And so a lot of entrepreneurs and operators said, what's my fastest path to big revenue? Okay. And in this country, the lowest hanging fruit to building a big healthcare business was selling into employers. Employers comprise kind of a third of this country's healthcare population that is covered by employers. And so, and then you're selling to a central buyer that usually covers thousands, if not tens of thousands, if not hundreds of thousands of lives. And so a lot of the market got focused on how do I sell it to an HR benefits person or broker or commercial insurer, and then distribute it via HR to these B2B populations. What it does is it, first of all, neglects 2/3 of the country and just limits you to what you can sell into employers. In our case, we said a couple of things. One is there's still 2/3 of the country on Medicare or Medicaid or uninsured or an individually bought ACA plan. Right? There's a lot of people who have employer-sponsored benefits, but are on high deductible plans. So actually, when they get insurance from their employer, they go out and look for a primary care appointment. It's mostly out of pocket because it's a couple of $1,000s before any of that kicks in. And so what we said is we have to figure out an efficient way to reach those people in those aspects of their life, not through some HR email. And so to do that, we wanted to be, I think, as diversified as possible. So today, for example, we market our primary care through a multitude of channels from literally having the smart TV in your home, which is in our case through our partner Samsung, show a telehealth option on the home screen of your TV, to having pharmacy partners advertising your telehealth service at the pharmacy counter when you're picking up your local prescription, to having a text message or postcard come from your health plan saying we're covering these virtual annual wellness visits, come and get it done with our partner HealthTap, to your health system advertising a billboard on the side of the highway saying we now offer virtual care powered by a partner, right? So in all of the ways that organizations in this country kind of reach patients around their healthcare, we want to bundle primary care because it really touches everything. It really touches everything. Another big one I forgot to mention, DME suppliers. You know, there's a third of this country needs DME on a regular basis. And so they're in touch with a lot of Americans, often with the friction around getting their DME refilled, right? Perfect moment to introduce virtual primary care. So you need to wait 4 weeks to get your catheters resupplied. There's no need for you to schedule a physical in-person appointment 4 weeks from now just to get more catheters. It's kind of a crazy situation.
Yeah, I remember. It's funny you bring that up. I remember I was going to India and I needed to get I think it was like a malaria refill.
Yeah,
and I messaged my doctor. I'm like, "Can you refill it?" And she's like, "You got to come visit. You got to come. You got to come talk to me in a week from now." And I'm like, "But
it's crazy.
I'm going to India.
It's crazy."
So I hear that, and
it goes back to why I was passionate about the idea behind HealthTap. Is I grew up with an uncle who was a doctor, who was my doctor, right? So me getting travel medicine or an antibiotic, whatever, was a late night call to my uncle or a text message to him, and he would always pick up. And he didn't need to see me in person. He's like, "Sure, I'll call it in. It sounds like that's what you need, and we'll take care of it." And so, what percentage of the country has an uncle doctor, right? And but it's not that they can have that experience. And when you have that experience, it's a game changer. Healthcare is so easy. It's not expensive. It's not hard. I wasn't burdening my uncle doctor, right? And so if you could create that sort of like light touch access, then all of a sudden that malaria refill is like a quick text message to a doctor that he or she can respond to without taking up 20 minutes of their time. And administrative overhead.
Or your time. I think there's an interesting segue into, maybe let's talk about why certain investments in digital health haven't worked out, right? Because you spoke about, it's all about top line growth. It's about, can you go to the self-employers? Can you go to the employees? Can you go through whatever level of distribution? But we see massive checks going into healthcare, and a couple months later, a couple years later, you see the company's no longer around. Well, why do you think that happens?
I think what has happened, especially through the pandemic and the boom in digital health funding, but in general, in the first 10, 15 years of hype around this space, is a lot of companies raise a lot of money with very high expectations they have to grow into quickly. That pressures them to spend that money and then grow into that money through whatever means they can. And so they're either going to reach escape velocity or burn to the ground. And that's just a very high risk, high reward sort of situation. For better or worse, healthcare is not designed to move quickly, right? It's an industry that requires trust. There's a lot of inertia in place, almost by design, so things don't break too quickly, that it moves like molasses, but when it does, it moves fairly permanently. And so as an entrepreneur and investor, you need to go into the space with quite a bit of patience and resilience. Don't look for your exit in 4 years. Look for it in 15, 20, 25 years. And with that, raise appropriately at each stage for the next stage of growth, because your next set of customers might take you 18 more months to land, and then a cycle of proving them out in another 18 months. It's not like, some SaaS business where you can get 1 million signups tomorrow and the 1 million becomes 10 million next week, right? So I think one of the biggest issues has been that, which is these undue pressures to grow your companies quickly cause flameouts. And unfortunately, it busts the bubble in a way that ultimately affects patients and doctors, because they get a lot of false starts and stops, right? Here's the technology, here's the solution, it's going to change your life. Boom, it's no longer there.
It trickles down. It trickles down, unfortunately, to the people that matter most. It's the patient, is why we're trying to do all this stuff from the beginning.
Exactly. I mean, we don't need to talk about specific companies, but like, it's just in the news today about the unfortunate situation with 23andMe, right? It actually is still a company with a tremendous amount of promise, but it had a lot of financial pressures to grow in a certain way with the investors that had poured a lot of money into it. And so I think it's just a very relevant, timely example.
Yeah. Well, and that same thought track, you got hospital systems, healthcare systems, right, that are really under a lot of pressure and not always doing well financially and looking for solutions like you have described. Like, where does digital health play a role in helping either improve margins or profits? Like, how do you see HealthTap helping with that type of a problem from a hospital or health system standpoint?
Yeah. I think one of the challenges health systems have is when they think about using technology, they end up on two sides of an extreme spectrum. Either they're talking about very core, quote unquote, low tech functions like RCM, like EMR, not to call them low tech, but to mean like they're just fundamental infrastructure to running the business. Or they're on the other extreme of like AI and super cutting edge use cases that are not yet proven, but may have ROI like 5 to 10 years from now. There's just a lot of technologies in the middle. They're not that high tech that can drive a lot of value. And they may not even be tech at all. So in our case, for example, when we work with the health system, our value proposition is quite simple, which is you're probably operating some brick and mortar primary care clinics and urgent care clinics, and they cost you a lot. And it's really difficult to turn a profit. Reimbursement's not very high. You have a lot of overheads to run those facilities, try to make sure they're efficiently utilized, bringing patients in. And a lot of them, for better or worse, again, are designed to be loss leaders. They're not meant to make a lot of money or any money at all. They're meant to be a way to engage patients so that when the patient needs something that ends up being more lucrative to the health system, they get referred in, right, with a trusted relationship. And so when we talk to the health system, again, without talking about AI and chatbots and LLMs, simple value proposition. There's a way to use technology and maybe a new business model, which is outsourcing your PCPs to lower your costs and still get the downstream ROI of the referrals to your specialty centers, right? And so I'm not really selling anything crazy fancy there. It's just a new way of thinking how to run a business unit. Like a kind of silly analogy I use is you could build your own support center or call center, or you could outsource it to a company that provides turnkey support agents. Mm-hmm. They could probably give you more scalable, service at a lower overhead and cost per unit than you building the whole function in-house. Yeah. And it doesn't mean move it all outsourced, but it means like maybe keep it 50% in-house and 50% outsourced, right? But keep it deeply integrated. So as far as your customers are experienced, they don't know what's in-house outsourced, right? So I think there's a similar analogy with primary care, and it's getting resonance, right? And it's a very it's like a CFO level conversation. It's not a CIO level conversation, right? Yeah. Tech is kind of one of the ingredients of what makes it happen.
Yeah. So in this industry, when it is moving slow, slow as molasses, right? Like, how do you engage a CFO in the right timing and context to give the detail that you just provided on what primary care digital health can do for them? Like, how do you get that momentum to start shifting the thought process or a paradigm shift in an industry that moves so slowly?
Yeah. I mean, a hospital and health system is often a very multi-stakeholder operation. You guys know this very Absolutely. Intimately. We have found that the pure financial pitch is kind of the easiest way to hook in, because at the end of the day, they're businesses. Yeah. You need to show an ROI, and you need to show how it affects their P&L. And so the CFO is the right starting person in our case, because it creates the business case, it justifies the engagement. However, even in our cases, the CFO needs to make it to your clinical and operations leaders to say, we're going to be rolling out primary care in a new way. And then the marketing team needs to be bought into the branding and how it's marketed and how it preserves kind of local brand loyalty. And so that's a long-winded way of saying there's no shortcut around the hard work that needs to be done to engage all these stakeholders. You have to find what's your wedge, who's a stakeholder that's going to hook you in. And then, some customers will self-select. Some will raise their hand in the market and say, we want your solution, I've heard of you. And so, of course, you need to react to that. They are your early adopters. But I think you have to be, as an innovator and operator, smart about choosing your customers. You could hire the wrong customers, and they could actually hold you back and distract you from customers that would have launched out, rolled out faster, and done more, and built a better case study, and then been a role model example for the 10 other customers that still wanted to buy you, but should buy you probably 3 years from now after someone else has figured out. So I think culture matters in your customer too. Culture, willingness, appetite, hunger, pain, urgency.
Yeah.
Like those stars kind of need to align. And
one thing that we've done quite a bit, and we do, and I think it's one of the hallmarks of our business, is we co-develop with customers as well. I know we're working on some stuff together there as well, where customer knows a lot about what's going on, and I think we have the technology to back it. And so even if you look on our website, it says, co-develop with health systems, right? Yeah. And I think it's about striking the right balance there, to your point, where it's, you don't want to be fully driven by a customer's roadmap, but at the same time, they have some insights that we sitting here are not going to get, right?
Yeah.
And so,
as technologists, we like to come into situations with a disruption mindset. We can blow up this terrible way things are done and overnight fix it. But like I said, healthcare is almost designed not for that to happen.
Yeah. Right.
And so co-developing is another way of saying, like, let's incrementally build on what you're doing to build a roadmap up to what we want to eventually do. Yep. It's just about phasing the work and the disruption in a palatable way.
Yeah, it's true. And I think one other thing we hear, and maybe you can comment on that as well, is when we go and roll out our SAM service or our scribing or whatever, you always have your early adopters, and then you have those that will say, I'll never use an AI scribe or digital scribe. And that's okay. In the beginning, you don't have to. I think when you see your colleagues around you looking at it and then going home 2 hours earlier.
Yeah. Most quotes that say, I will never use X technology don't age well. Yeah. They just adopt it a little later than everyone else.
Which is okay.
Which is okay.
And I think we think about the tranched approach. And
it's how the normal distribution works. You just have to be mindful at who your innovators and pioneers will be along with you.
Absolutely.
Yeah.
Absolutely.
Because you could just go bankrupt trying with the wrong customer.
Right.
Yes.
Right. And then again, who does it affect the most? The patients and doctors who never get a solution. You were quite passionate, would have been the right one for them.
Absolutely. I want to, I know we didn't speak much about AI earlier, so maybe want to move to that now. What is the most unique application of AI that you guys are working on right now that it's worth talking about to the audience?
Yeah, we didn't optimize for uniqueness. It was really what is the right balance between useful and safe.
Sure.
And the use case that we started with when, LLMs really had a breakthrough moment in their performance was patient interview and intake. Essentially, we realized there's this time before a visit where, you need to take a lot of history, and historically has been done on clipboards with forms that are really mundane and don't actually unpack the nuance. Okay, when did the pain start? How did it radiate? Where did it radiate to? Does doing this help? Does doing this not? So, these LMs are pretty smart at asking the right follow-up questions. But then once you do this interview, which the patients are very happy to do because they're going to do it and get it out during the doctor's visit or ahead of time, is the LLM can actually summarize it in a way that lets the doctor come up to speed in a fraction it would have taken the doctor had they had to have the live back and forth conversation. And then not only does it summarize it, it puts it into the note and starts the documentation process. So not only does it let the patient doctor dive into a deeper, meatier conversation to get to the heart of the matter and solution design for the case, but it saves the doctor precious administrative time. So it was kind of like a check. And it's safe. It's not doing any diagnosis, not doing any triage, right? So the risk of it asking a dumb follow-up question is you wasted 10 seconds of the patient's time asking a question they didn't need to answer. And the doctor will just ignore, right? So that technology is called Dr. AI. It's something that you can complete before a primary care appointment on HealthTap. And it's been incredibly popular. We've actually been secretly looking at the diagnosis it predicts and seeing if that's what doctors are doing. And it's actually kind of good at diagnostic suggestion too, but I think that is a less safe, more nuanced use case that we have to be careful about rolling out, which is clinical diagnosis support.
Yeah.
That's amazing. And so when you roll out new technologies like that, and you see early adoption, you see positive trends, what drives your decision-making process for the next step? So you saw some, again, positive momentum. Do you build on that? Do you pivot and do something net new? Do you take, again, clients' advice or, opinions into consideration? Like, how do you know what to do next steps after you get something that carries some positive momentum?
Yeah, I think one thing that surprised me is it's really tough in healthcare to innovate for the purpose of innovation or care quality or patient safety, because you need to have a quantifiable business case. In so much of healthcare is fee for service. You get paid for what you do, not more, not less. That as a pragmatic operator of a business, you focus your time and efforts on things that make sure the business is sustainable and growing, right? So sometimes these more innovative advancements don't really come with an ROI that you can measure. So you're like, how can I use my precious resources now in hopes of something good to come out of it? And it's a terrible thing to say, but I do think that's where value-based care and some of these bigger shifts in how practices like ours are compensated will help, right? Because now, if my world is not about being paid for services rendered, but being paid for services avoided, essentially, I can find more ways to use technology to kind of come in and prevent the visit. Then, unfortunately, right now, I do not have the incentive to do, which is not to say that, you want to build a business that drives overutilization. That's where kind of ethics and morality need to come into play in delivering healthcare. But it is unfortunate that I don't have a mandate as a business with the right economic incentives to innovate for the sake of innovating.
Going to a slightly different topic, say you weren't running HealthTap today, and not saying that's going to happen. I think you guys are doing an excellent job there. What's a large problem in healthcare that you would be attacking, or maybe you're adjacently working on that at HealthTap? Another big swing, another big bet that you're taking?
Oh man, there's a lot of questions. It's like, what are questions that I would love to see solutions for versus what I'm personally passionate about? I mean, there's a lot of low-hanging fruit problems in healthcare. Isn't it crazy we still don't have a national provider directory that's up-to-date, accurate of where every doctor works and what insurances they accept and what their schedules are? It seems like hello, there should be like a Wikipedia of doctor profiles. Someone should have figured this out. This does not require crazy tech. So there's things like that you still kind of scratch your head and say, there's probably an easy technology solution. It's probably hugely impactful and could make a good business. Who knows? But then there's areas that you're just passionate about. Like, I've had a lot of folks in my recent life that have been affected by cancer. And so I do think a lot about how prevalent cancer has become. And I think particularly in the cancer journey, it's really hard to get personalized medicine, right? And get your cancer analyzed in a way that can open up certain clinical trials. There's a lot of situations in stage 4, late stage cancer that there are medicines that could work that you technically have the right to try, but most patients aren't savvy personal advocates. So having just gone through it personally, I think that would be an incredibly rewarding business to focus on, is helping people in that very vulnerable time in their life and their caregivers navigate the system for a very scary disease. But then again, there's a lot of unsexy, easy stuff that you could also solve.
and some of those aren't even really tech problems; they're more coordination problems, right?
Yeah, exactly.
The tech is, to your point, it's a database. I think the hard part is keeping it up to date, make sure everyone complies.
I really think most of healthcare has a low tech solution to it, not a high tech solution to it. And it is, I said the word unsexy, it is like unsexy work in Silicon Valley perspective, because it's not using cutting edge R&D. But that's really where value is created. It's in the human element, it's in the coordination, it's in kind of marketplace matching, it's in data aggregation, consolidation, cleanup. It's in this really basic stuff. But you just need passionate entrepreneurs that grind away every day. I mean, RCM is a classic example, right? Of just grind away work that has a huge potential impact, but
The thing that we found with RCM, and we kind of stumbled upon RCM as we initially had our remote monitoring products, is it didn't matter how great your technology was. It didn't matter if you had the most innovative solution in the world. if the practice couldn't keep their doors open, it didn't matter.
It's the lifeblood.
Right.
It's the lifeblood. Yeah.
And so that's why it's been a pretty rewarding journey there, I think, for us. And, when I sort of joined Aphellis, I didn't realize how big of a market it was as well. And maybe just talk to us about some of these more coordination tax problems that are low tech. Just help the audience visualize how many people could help and how big some of these healthcare markets are. Because I think, like, you look at like the Department of Defense, and I think they have an $800 billion annual budget, and then there's $4 trillion of healthcare spend. So healthcare is like 5x that of defense.
Absolutely. I mean, numbers on the healthcare market are, we spend about $15,000 per person in this country per year. It may not be coming out of your pocket, although it is increasingly coming out of your own pocket.
It's true.
But you're usually paying indirectly through taxes or kind of employer contributions out of your payroll, right? And so that is a ton of money as a percentage of the Americans' overall income.
Yeah.
And when you think about, you asked about how much is coordination an aspect of all of that, and poor coordination. Being in primary care, we are what 80% of people need 80% of the time. But our role in people's lives is part coach, but it's part navigator. Really, at the end of the day, your primary care doctor is an orchestrator of the entire value chain of healthcare. They tell you what drugs to go pick up and buy. They tell you what labs to go get ordered and take. They tell you what DME you should go and purchase. They tell you what specialists to go see. I mean, you name it. Usually your primary care is the first and last stop to figure out where else to go. And so we see coordination all the time. And the crazy thing is, I want to build a practice that is highly integrated around the country. Like, it would be nice if my doctor said, you need some imaging. You need a CT scan or MRI for this thing. And I'm going to push a button and the order is going to show up down the street at the radiology lab that I know is 2 blocks from you. I can't do it. I can't do it. The plumbing doesn't exist, right? It doesn't even exist for a lot of lab testing companies. Thankfully, we have good infrastructure on pharmacy. But the point is, there is so many points where that next step beyond primary care is totally just broken and it's manual.
Yeah.
And we joke about how much faxing and phone calls is, but that's really what it amounts to.
Yep.
So honestly, going back to your previous question, when you think about like what are some exciting business that you want to build, I would think about the pipes that link all of this care coordination needed, so that it can be digital and electronic. So it doesn't require a whole back office of people exchanging faxes and using AI to interpret faxes. Right. So you think about like when you think about like what should AI do? I almost like to ask the question, what can we eliminate that we don't even need AI to do? You can get AI to like OCR some faxes for you, or you can eliminate faxes entirely. And I think maybe we should focus on simplifying the system before automating a complex system.
Yeah. I mean, we still deal with certain payers that only accept mail submission.
Right.
And I'm like, what year are we living in?
I know,
where that's the case. That kind of answers like, yes, you could OCR the response back, but just accept the digital submission to start with.
Exactly.
Also, I wanted to put into context, you said $15,000 per person in healthcare. Our GDP per capita is about $70,000 to $80,000 a person. So I think that puts that into perspective.
Absolutely. Healthcare is 20% of GDP, and it's getting increasingly more expensive at a rate higher than GDP growth. So it is unsustainable. Short of disruption, it will break. But I think we, as agents of change, need to approach that disruption over the next 10, 20 years and not expect overnight change. And I think we should kind of cool our expectation of what AI is going to do and the role it's going to have. AI is going to be incremental before it is stepwise function changes. Like we will optimize the efficiency and productivity of existing resources for a long time before we replace resources entirely with automation. And that's good. To be honest, that's good. Because, mistakes in healthcare are disastrous. Right?
Yeah, that's interesting. So tell me some of the barriers. Again, speaking, I've done some telehealth myself, right? Obviously not primary care, but what are some of the barriers you see from an adoption standpoint when you roll this out? You get a contract with any of those options you talked about for employers, whatever it may be, even a payer agreement, right? Where do you see resistance or a lack of actually adopting the telehealth option when you're rolling this out to a new group?
A lot of it is pre-existing biases or assumptions that don't turn out to be true. 15 years ago, consumers and the industry in general would tell you, you can't provide care without putting your physical hands on the patient.
Yeah.
No one says that anymore. It's like, no, there's a lot of care you can do virtually. We've seen it. Now we're living in a time where the biggest barriers to adoption are, like in our case, I thought primary care was only for the cold and flu. I didn't think I could use it to manage my diabetes or my hypertension or screen for my colorectal cancer. But it's like, no, there's models that exist that do that. And we raise our hand and let's explain to you what longitudinal relationship-based primary care is and how that's different from the telehealth you're used to. Or it might be things like, yeah, but I have an in-person doctor. Why would I need it? Like, okay, let's think about it. How easy it is for you to get an appointment. What happens if you need to get in touch with him or her over the weekend? And then you think through it and you're like, oh, wow, I can see a world in which I have a virtual PCP alongside an in-person PCP. So it still takes a little bit of that. Like you need to get that light bulb to go off in people's heads. So I don't think we're out of the responsibility entirely to do some education. But the barriers to adoption are exactly that. They have a preconceived notion of what telehealth can or cannot do, and they make their behavior and decision on whether they're going to use it based on that.
Yeah. But it goes with both sides, right? Is the provider does a provider want to do telehealth or not?
Yeah.
And then is the patient, like you just said, do they perceive the value in having telehealth when they already have a primary care provider of 20, 30 years? They've always gone to the same time. It bears both ways. So how do you go from that 1%, like you said, went from 0 to 2 with COVID and then back down to 1 post-COVID?
Yeah.
How do you go from 1 to 5 or 10%?
Totally. Exactly.
Next
In this country, 25 to 33% of people, depending on where in the country you look, haven't seen a primary care doctor in the last, year or two. Okay. And so that's a baseline of how many people should have a doctor that don't, right? When you look at the two main ways people think about telehealth, it's either, the model that the teledocs of the world have kind of made us accustomed to, which is, okay, it's kind of like a call center with a nurse or doctor to triage my symptoms and deal with some kind of low acuity thing in an urgent care situation. Or it's the MyChart messaging I have with my doctor with once in a while video follow-up.
Yeah.
Both of those things as paradigms are entirely different from go to an online only practice, choose and keep a doctor you love and manage your ongoing chronic conditions and health goals. It's like totally different. And it's like, oh, that's telehealth too? Yeah, that's also telehealth, right? And I think when that light bulb goes off, then the adoption, and then when they try it, they're like, this is game changer. So that's just kind of where we're at. Yeah.
And one question I want to ask there, whether it's for your partners, whether it's for your colleagues, the big benefit of telemedicine is you get time back in the day as well, right? Where you're able to see more patients, you're able to use some of this technology to automate your documentation, you're able to cut down on your admin tasks, your manual admin tasks, right? If we get the piping right.
Right.
What does that do to their quality of life, you think?
For the physicians?
For the physicians.
Well, so more than increasing the panel size of the physicians or increasing their throughput, like, instead of 10 patients a day, they now see 20. It's more also about efficiently utilizing their schedule, which is, I recently did a post about this, but a lot of physicians have these Swiss cheese schedules where maybe because of cancellations or inefficient booking and there wasn't enough patients in their geography to walk in, they'll have 20, 30% of their calendar just dead, like unutilized. But there's a patient 400 miles away that could use that 30-minute slot between these two other patients, right? So if you can just more efficiently utilize the time where they are in office working, that alone is a game changer. It's like effectively increasing physician supply by 20, 30%, right? And then, just going back to your question was...
Just their quality of life.
The quality of life, right? Physicians are no different than other kind of highly educated people, like engineers who go through school, get a very specialized skill, and now benefit in the world with work from home and hybrid work, right? Why should physicians be forced to come in when, honestly, most of their work is also knowledge work? They're not manual physical laborers. They do not need to work in, a blue collar job like doing manual labor. And so the idea that they can work from anywhere, set their own hours is like, thank you. Finally, I can do what my peers and friends that I hang out with in my personal life do too. So I think that's the game changer. When you talk about physician burnout, It's not just about reducing their hours and reducing administrative burden. It's like if they can take some evening shifts, they can put in a few hours in the weekend, they can free up time to take their kids to daycare during the weekday, right? These things matter a lot.
Super impactful.
I can't imagine how much happier I am post-pandemic versus pre-pandemic, not commuting. Simply alone in that fact, am I way happier? And so these sorts of things actually affect physician happiness significantly.
Have you done any or seen any studies on that? So I love that because, again, it's trading time for money, but also you have to be at a clinic and wait for the patient to come to you to trade your time to earn a living, right? And now, like you say, you streamline that. All of a sudden, the patient has more time, the physician has more time. When they show up for the next encounter the next morning, their documentation is done through technology, right?
Yeah.
They're a better version of themselves. Of course, they're going to render better care. They're going to have less burnout. Like, have you seen in your business or in other studies, like objective data supporting that thought track?
I'll give you semi-objective, somewhat subjective data, but like the anecdotes consistently at HealthTap of patient reviews about their experience using telehealth, going back to kind of preconceived notions, is physicians, the physicians are perceived to be more attentive and better listeners in virtual care settings, right? They're less distracted running around the office, popping in and out of patient rooms. They're literally sitting at a desk, looking at their webcam, right? Staring at that patient. In our case, our clinical model is a 30-minute visit, which is like 3 times longer than most doctors have with a patient. And patients walk away with, wow, I have never had an unrushed conversation with a doctor. And doctors realize I'm having a deeper impact on my patients, connecting them with them better virtually than I ever did in person, which is 100% counterintuitive to most people, right? How can you build a connection with people if you don't meet them in person? It's because you're actually there listening undistracted, right? And making eye contact.
Yeah.
So I'm sure we could pull data around it, but I'm just telling you anecdotally, that is one of the top testimonial attributes we get is my doctor listened and I felt unrushed.
It's impactful.
Yeah.
It's powerful.
Yeah, for sure. And if you think about what drives outcomes, part of it is access, but there's this other side, adherence. It's like, okay, I got the care.
Yes.
Then I'm supposed to do the things the doctor said. You know, when you do something is when you fear or respect the person telling you to do it. Right? It's just a very human thing, right? So like when your very strict dad is yelling at you to do something, you're going, okay, I'm going to do it, right? And so what happens with trusted physician relationships is it's less fear and it's more respect, obviously. It is, man, this doctor really knows me. I can tell they love me. I mean, especially when you've had a doctor for years, right? And they know your grandchildren's name. They knew what your grandfather did for a living. And that when they say, look, buddy, you should probably take that pill or you really should get that procedure done, you are way more likely to do it.
Absolutely.
And way more likely to do it on time. And that has a bigger impact to people living longer and healthier than like anything else, to be honest.
Yeah. Awesome. Well, I think that's all we have.
Amazing.
Thanks so much for the time. We really appreciate you coming down here. And thanks so much.
This was a fun conversation, guys. Thank you.
Thanks, Sean.